Half a day. Good morning. The Committee on Health, Tourism, Historic Preservation, Land and Justice is now called to order. Today's Monday, November 30th, 2020.
Can I start video because your host has stopped it? Okay. Spencer.
Ron, can you put your microphone on mute, please? But turn on your video. All right. So our committee's called to order. Today's Monday, November 30th, 2020. The time is 9:02 a.m. Notices for this confirmation hearing and public hearing were disseminated via email to all senators and main media broadcasting outlets on Friday, November 20, 2020, and again on Friday, November 27, 2020. The notice was also published in the Guam Daily Post on Friday, November 20th, 2020, and Friday, November 27, 2020. The Zoom meeting is hosted by the legislature's MIS and AV staff and my staff as well. And they will mute all Zoom participants until called upon by the chair. We have two agenda items for today. One is a confirmation hearing for the Guam Ancestral Lands Commission. Mr. Ronald T. Laguatnia, who's been nominated to serve a term length of 4 years from September 18, 2019 to September 17, 2023. We also are going to hear Bill number 388-35 COR, sponsored by Vice Speaker Senator Talina Nelson. It's an act to amend sections 41810 of Article 18, Chapter 4, Division Title 26, Guam Administrative Rules and Regulations. Amends sections 67.303C and 67.304A and 67.308 1 JKL of Chapter 67, Title 9, Guam Code Annotated, relative to the registration of prescribers to the Guam Prescription Drug Monitoring Program, enforcement of the patient utilization report, and the required disclosure of potential risks, and to provide an option to fill for a lower quantity prescription. I'd like to thank my colleagues for attending. We have this morning with us the Legislative Secretary, Senator Amanda Shelton, Senator James Moylan, Senator Mary Camacho Torres, Senator Regine Bisco Lee, Senator Will Castro. Thank you all for being here. All right, so we will begin now with the appointment of Mr. Ron Laguatnia. I want to confirm that Ron is on screen. Mr. Laguatnia, are you able to turn on your video?
Audio so far, but the host, it indicates that it does not allow me to start the video. It says you cannot start your video because the host has stopped it.
All right.
Can you hear me?
Yes, I can hear you. If you could just try one more time, and if that doesn't work, go off and come right back on.
Okay, go off and come back on. Oh, there. Yeah. Okay, let's get.
Okay, thanks.
This must say.
All right, all right. So So your appointment is for a term, 4 years, from September 18, 2019 to September 17, 2023. Before we hear from those who are here to testify on your behalf and from you, I'm going to just read some of the few duties of the Guam Ancestral Lands Commission. The Commission's directed to establish and maintain 5 separate registries for the purposes of recording information in the settlement of ancestral claims. One registry is the Original Landowners Registry, a listing of all lands taken under the names of owners of record at the time of taking, whose properties were confiscated or condemned by the United States of America or by the government of Guam on or after January 1, 1930, as well as other pertinent location and ownership information in relation to the property. This registry shall be used for the purpose of confirming an applicant's property claim for future extinguishment and just compensation. The second is the Excess Lands Registry. It's a listing of all lands that have been declared excess by the federal government, including lands declared excess in the future, shall be used for the purpose of identifying its specified lot or lands, which the Commission may use as just compensation in extinguishing ancestral claims. Third is a Claims Registry, listing of all claims to ancestral title filed. Fourth is a Conditional Awards Registry, listing of conditional awards of just compensation. And fifth is the Ancestral Title Registry, listing of applicants granted land title in return for the surrender of all their ancestral property claims. Other duties include to investigate, record, file, report, respond to requests by ancestral land claimants for remedy, including the government of Guam, whose land was taken by the US or by the government of Guam on or after January 1, 1930. This includes just compensation. It's as defined in 80101, which for purposes of this chapter is defined as limited to the return of land or access to landlocked lots across public lands, if public lands block access to private property. And of course, to establish rules and to extinguish claims and to determine the just compensation awards. All right, so first we'll hear from those who signed up to testify on behalf of Mr. Laguatnia, beginning with Mr. John Birch from the Guam Ancestral Lands Commission. He's the director now. Mr. Birch.
Yes, thank you, Madam Chair, and good morning to you and to the other senators, Senator Torres, Senator Moylan, Senator Castro, Senator Lee, and Senator Shelton. Thank you for this opportunity to testify in support of Governor Lou Leon Guerrero's nomination of Mr. Ronald T. Laguatnia to continue to serve as a member on the Guam Ancestral Lands Commission. And with the consent of the legislature, not only will Mr. Laguatnia's reappointment complete the composition of the Guam Ancestral Lands Commission, it will help us to meet our mission of administering the Guam Ancestral Lands Act in order that ancestral landowners, their heirs and descendants, may expeditiously exercise all the fundamental civil rights in the property they own, and to provide just compensation for dispossessed ancestral landowners, and when appropriate, assist ancestral landowners in the pursuit of just remedies. Mr. Laguatnia's nomination for reappointment is testimony to his commitment to serve and understanding of the great responsibility this position requires. I look forward to Mr. Laguatnia's reappointment to the Guam Ancestral Lands Commission, and I thank him for agreeing to continue this hard but rewarding work. Therefore, I humbly request the legislature to move forward quickly in filling this position. Thank you, Madam Chair, for allowing me this opportunity to testify in Mr. Laguatnia's nomination. Thank you.
Thank you, Director Birch. We will now hear from the nominee, Mr. Laguatnia. Thank you for being willing to serve in this capacity again, and you may present any testimony that you would like.
Minagov todos dan hafade, todos samso. Especial na saludo para hago Senadora Therese Terlaje, dot como hago, in mas gehulo ni komitenetano, era mas para esti komisionitano imanainata. Pareho para hamzulokki, iman pumalo na senador dan senadora, lolonya si Senadora Taitagui, Senadora Torres, Senadora Lee, Senador Castro, dan Senador Moylan. Saludo dan hafade. Donkulo na agradecimento dan sejus maasi na unaizu no este na oportunidad na para baihu presenta e testiguho como un membro at kadre ni komisionetano imanainata mucho mas i Guam Ancestral Lands Commission. Pag utsatsagisti na manera ni para bai fantastigo gimenan minzo lo betsagi mano ni na senyo. By introducing myself naza ko sa kiu matungo gipapit dan gireckon na mahong dan honga haji jo na tautong. Si Ronald Tenorio Laguatnia jo, familia Labutsu, familia Nastanao na banda. Laguatnia, i familia Gaddi, gesta tao na banda. Tautau dedu jo lo hagas gi mansinanya ham na familia. Guahu i et mas patgun ki entry dies na manelo. Nilahin anang Katlus Laguatnia. Imanelu siya itutuni at masamko si Lilian L. Mariano, si Katlus Tenorio Laguatnia, si Andrew Tenorio Laguatnia, si difunto Edward Tenorio Laguatnia, si Lucy Tenorio Laguatnia Vasquez, si difunto Vincent Tenorio Laguatnia, si Beverly Laguatnia Borra, si Dorothy Laguatnia Benaventi, si Lawrence Tenorio Laguatnia, Zangwao uttumo maspatgun. Tau dedi duzo. Umentis ti sa megayam na manelo. Zagwawa yun maspatgun. Zaginin siya imanamko ni amanamko maniluhu nahu kakarga imigay minen halum ginin siya ni mapoksayo. Pahihusangan di pudi hinalomho gi komisyon sa ni Chetsu ni ginagaw niya. Esta benti intingo na hagas do mataotsong gi na estaw como membro disti tatti gi 2002 nasapkan. Disti anay gagi oficinan mami gwati gi zani gwat gilihing mais o sino i-corn building ni matungo ni antes. Tayo gusto dyan nalihing. Zano sa manana pago. Adyo na lugar. Umanok siya pago gima adyo lohan gisan tatti. I-permit ihinalom ho como membro. Gidurante niya magalahin Felix Camacho sa City Punto Ed Benaventi. Imagalahin ni Nasyon sa Moro. I-director Mami Gwinatempo. Guida i segundo na direktor gumahilui i komisyon sa antes di Guida si John Camacho Sibado. Guida i primer direktor gehilo i primer siya na member siya loki Guida tempo si Mark Chotfers, si Antonio Sablan, panan si John Manaytay Bodra, nangagi loki Guida si John Manay Garido ni Hagas Manami Ginasyon sa Moro. Yung hasu loki pamalo siya lo tanayan mo sa ginensiya ni Tsumoning na 3 kilo tsotso. Yagi loki si Teluta si Join Leon Guerrero sa estapago manahame loki. Pudi ni nanalo ni Tano siya tatigi manirina na duenyo. Todum ni man membro pago sa nantis. Man matsuli itano imanaynata zan fiet zan fit mi isinenten mami para bayin nanalo tatti siya itano guato gi imanurina na duenyo. Y después de ano siya na humenti, humalom si David Camacho, direktor, pues si John Ngoko, pues pago si John Birch. Mamparewas di siya na manmagas na para uajuda imatataw ta siya. Ni para mananalo tatti, iman makundena siya na tano, ni man masopta gini ni federal. Justisya iminalago mami dan iminalago mami todo gini manawtawam para matsuli tatti ihaga si John niya. Esti tano sinata alo nata aazawa gi ifamagoonta. Sa siyaw fanatati siyaw miresi kumaman matahit. Matayahit sa gagagya itano. Parewa da ni Kebri. Bendi itano gagagya itano loho ko kay Kebri. Siya ifamagun niya, zan ifamagun niya. Ufanatati loki. Sa siya o mapasas ti siya na tano papag ifamagun niya, dan ifamagun niya, zan siya muna. Ipunto siya na importante para waho, gi komisyon. Isumen importante na pabesigya o milaw, zan ispiya siya na familia. Ni manggay tanong sa gayga inumeron il solaritano gwihi gi tax row. Gayga ilokasyon lo meggay sta man matay. Meggay manggay gi sanlago. Dati matungo na manggay tanong. Sa siya no siya para irensya esti siya na tanong. Mga mana falingo. Hamen ni komisyon uniko gipunton mami na para insigi umaspia imano ni nasinan mami para ben sedda esti siya na tautawis ko sa kisinya tanaw itati ihagasitano imanay nata ni man makondena ni federal na ni militar na manay itati gi gobyerno. Mina dos ipara impitsigi sa in apreba iya reglamento hamzo ni legislatura gaygis tagi kanay minzo na para en apreba i regulasyon zania reglamento. Kasi kisinya na pausi siya imanurinat siya na duenyo ni Kepli ni Enricoy dis di mamalofan siya na tempo ginini at kilet itano siya iyamanan siya no natono edi mafanana ni Crown Lands. Kaya gisti na kiabligi bang kunitano i-land bank ta siga manggana interes. Ja kasi man listam para entutun pumati hujung para esti siya. So fan matsuli takti itano niya aja tisinya matsuli itano niya pad ofan mana itati salak. Imina tres otro para ensigit sumunik ifederat para umananalo itano siya ni timan nisisita sa megay man timan manasesebi sa siga man maeskusa na manisisita lo lalalaya at siya na tono at timan nasesebi sin vida. Kasi maniluhu sa maninaho. Bayo na fakpuha bini itistiguhu zabe nekunguk babe ekunguk kamsu zabe opiak pa siya na kriston zabe tagi mono ni nasinyahu manusinya zagi nesti finohu pago na ogan na hudisesya na todo kita hamzu man favor da en confirmazo como único tetenan para o kabalisam 7 na membros zabe continua sumogi chetso sendongkulo na si Juus maasi todo samjo. Humenti na si Juus sa guizaha si Juus ti umiisaw. Esti isay na gaygiha gitano za umiisaw. Pues si Juus maasi talo. Dandongkulo na gudisimento sa gingamas Kristyon mo usangan esti sa mas niya jo maulik sininteko na pabeem papata isti ifinoho gi publiko inirat. Mas satun gijagwaw eto na sinya loki imam famagonta dan imam famagonia ni mamamala siya na tempo umahungok na gwagwaha lingwahita na matsotsogi gi publiko gi gobernamento zaman lalala ifinota gi gobernamento Guam. Kololonya mas gi legislatura Guam. Dan yung talo malagomo para may polayam su si mismo si imas katsongo gana papa si epokaigwi guida mismo gana mas na setbi no na kilisdano sa agogos danya para utsonik mona loki ilengwahi kita hamzu gi legislatura. Dan kolon na si mas si puri atensyon medyo dan si Sino Will Castro ne celutalo pues todo lo que gazamzo si Ryan haga studente ko si Ryan katsonga si Rosana dan pamalo siya ginaman na kung ganagi publiko dan si kinadaw gano si Senadora Mary Torres sa si Iding na dan si Sino James Moylan ni manwento si James gi umbiagi gi fundraising Hutuna Hamzo, Senator Therese, Senadora Regine Besco Lee, Hutuna Hamzo si Senadora Amanda dan si Telo manamya dan si Telo talo gi JFK. Si Jus mas dan si Director John Birch, si Jus mas si Senyor.
Si Jus mas si Senyor Leguatnya. We will, if I could just, you've been on I'm going to start off with my own questions. You've been on the commission before, and since 2002 to 2019, and then in 2019 your term expired, and so now you're coming back in. But since if I could just maybe ask Mr. Birch. Mr. Birch, can you just clarify? How long has this position been vacant? Because the nomination paper says September 2019.
Yeah, Madam Chair, when I saw that those dates, I tried to reconcile and find out what happened. I was informed by the governor's office by Mr. Mike Weekly, who handles these appointments, that based on the appointments of the original dates that Mr. Leguanya's term would have expired in September 16, 2019. Apparently there may have been some confusion as to when, because I was informed when I arrived about mid part of this year at Ancestral Lands, I believe around June or July, that all of the 5 vacancies occurred at the same time on March 26, 2020. So I'm hoping that the legislature would be able to reconcile that. Currently, we don't have access to some of their files at this point in time. We're still working out of temporary offices in the ITC building. And should we somehow get our funds advanced to us, we will be able to set up a more permanent space, but we are having issues with BBMR releasing funds to us for that. So that's as best as I can get, and that's what I received from the governor's office, that was the actual date that Mr. Laguarnia's term expired.
All right. And Mr. Laguarnia, have you served subsequent to September 2019? Were you active on the board since that time?
Again, yes.
Until March 2020?
Yeah, March 26, 2020.
Okay, I want to ask you one more question that I've asked all the other nominees that came down. So we received your nomination on November 10th. And so in 2019, there was an audit conducted by the Office of Public Accountability on the Ancestral Lands FY19 finances. According to that audit, FY19 revenues were at $6 million, a $2.7 million increase from FY18 due to increase in base lease rental resulting from settlement agreement with AT&T. The audit also reported an increase in expenditures by $902,000 due mainly to the increase in management fees incurred by Ancestral Lands Commission for GITA services. That was an increase of $752,000, 712%. GITA's increased fees pertaining to AT&T lease payments of $4.9 million. In the 2006 MOA, GITA retains a certain percentage of the rent collected as payment for lease management services. The audit states that the commission was to reevaluate GITA's role relative to its property management services on ancestral lands leased property. And it also reported an increase in salaries by $100,000. And so I just wanted to know if you had any feedback on this audit, if you have any thoughts on how to, if this situation could be made better, or is it?
Yes. Senator Dinancione, that is one of the big concerns that we are going to look at 14% at Kilutu. Even other institutions are saying that is a lot, but they are our management team, and with the director's guidance and the Pamalusya membership commission, we are going to look back at the MOU. We did discuss it prior to the ending of our tenure in March, but now since the pandemic, we are going to look at that and meet with them and try to bring that down to a reasonable percentage. That kilo, no, they garnered a lot of money, but
right.
Still we were still struggling, Madam Chair. So at the time, even prior to with the MOU with GITA, we also had challenges without an attorney. We were just working our way. We got into some court litigations. And yes, we are just to let you know that we are learning as we move on, and we're getting more smarter and wiser. But we are with this, mentioned that with other board members, that we're going to look at that MOU and see how we can work that 14% out. So that's a lot. And that's continuative, I heard. Constantly, every check that they receive from our leases, and they get 14% out of that, and that's a lot.
And I know that the commission, the biggest challenge facing the commission, besides I would call it minor challenges that you're having that for office, for example, when you separated from the Department of Land Management, you had to incur your own office expenses, and that pretty much increased everybody's expenses, and paying for a director, of course. So those, but I would call those minor compared to the big issue facing the trust are, pushing for the return of the excess lands that have been promised, especially since 2011, when they made the listing of which lands would be returned as part of the net negative approach on Guam. And then moving forward with how you're going to resolve claims from people whose land will not be returned for sure. Right, and that, as you described, and we look to these rentals, but I know that there are still issues that, as you said, need to be resolved through the rules and regs and through consensus. And do you feel that we will be able to reach consensus? Because I think this is very controversial at times. Yes, how we are going to take care of these?
Yeah, we are looking forward to making sure that we have an agreement. Monies have to be given out to our the heirs. We have placed it in trust, and they are gaining, and that needs to go out before at a fair way in doing so, Madam Chair. We don't want to miss anybody. We want to get everybody on the list for sure, and make sure that it is done correctly, because it is a very sensitive issue as to how we're going to disperse such monies. And we'll see, because some have more acreage, some have less, but at least we can look at it and come to an amicable solution with the help of our other board members and the director, and in fact input from the senators as well. We need to come together as one. So it's just unjust. I too have property that's on a runway, and my family's been waiting, and I only have one last heir, my uncle Goro Maguanya. He's the last living heir, and we need to get this justice finally put to an end.
All right, thank you. And my apologies, I want to recognize the presence of Senator Terlaje. She's been here since the start, and I just failed to mention. I'm very sorry about that. And thanks again to my colleagues for being here for this hearing. We'll now open for questions. Senator Moylan, I'm just going with the list I have here. So Senator Moylan.
Thank you, Madam Chairman. Mr. Laguardia, congratulations again. You're still willing to serve the people in the island of Guam in your capacity. I appreciate that. I don't really have any questions, but what I'm really hoping for with your experience with this commission is that you'll be really forthcoming. Of course, we know we have a lot of, want everything to be transparent as much as possible. And going into finishing up the 35th and going into the 36th, I think that we really want to help the people of Guam with the mission. And if there's something we can do at the legislature side, be sure to bring that up to our attention, and maybe we can address something to make things better overall. So I'm looking forward to hearing, not being that you're not quiet, not that you are, but I'm hoping to hear you speak up and really let your voice be heard and make the transparency happen for the people of Guam so we can all understand and move forward together. So congratulations and thank you very much.
Thank you, Senator. Senator Mary Camacho Torres. Yeah, I might have lost her. Senator Regine Biscoli.
Buenas and happy day. Thank you, Madam Chair, and thank you, colleagues, and all those who are joining us. Mr. Laguardia, I want to, express my indulgence to you for once again accepting Governor Lou Leonguero and Lieutenant Governor Josh Tenorio's nomination for your appointment to the Guam Ancestral Lands Commission. We all know how important it is that this commission runs smoothly and that we have these cases decided and so that people are able to move forward with on their lives. One of the things that the chairwoman and I both ask of many nominations to boards and commissions is just information about conflicts of interest. So I was very happy to see that you filled that section out in your packet. You indicated that you have no stake in any businesses and, you know, that there would be no conflicts of interest. So I appreciate that. I also wanted to just ask you about the time commitment. We've heard from Mr. Birch that, you know, there may have been some vacancies on the commission for several months. And so I know that they are ready and excited about being able to move forward. So I just wanted to ask you, given, you know, some of the other work that you do in our community, if you will have the time to dedicate to continue to dedicate to this commission and to show up to meetings to make sure that we have quorum and that the business of the people is able to be done. Sorry, Mr. Laguardia, if you don't mind just unmuting so we can hear you.
Sister Mossy, yes, Senator. Yes, I did. I am dedicated and I have the time. I've attended the last 2 meetings, even if I was not confirmed yet. And I put in a lot of effort in doing justice to the original landowners. And I run by the philosophy of doing what is good, what is right, and what is just. And many people know me when I'm at the hearings, at the title hearings, and any meetings that we have. I'm straight up. When monies are being spent at huge amounts, it's a big question in my heart and in my mind. So because those monies are priority for the heirs and the original landowners that they deserve. It's just that we're just putting it in trust. We're holding it and we're just waiting for getting the rules and regs, but honesty and integrity. And as for Senator Moylan, if I can continue comment, the transparency, Mr. Senator Magdalena, the first thing I'm going to ask the director is that once the new board is all in place, I suggest that we all boards, by mandate, by law, that we all again take that ethics training to remind ourselves again, because I have a few little things in mind that are questionable, but perhaps I can just set that on another time where we can discuss that in a much better forum. But Senator Gaigi Corazon, and I am there. I was there fighting with the late Angel Santos. He's my party, and we've been brother will. Everything is through the heart for the people.
Thank you very much. I very much appreciate it. And thank you for your participation, even though you weren't yet confirmed. My last question is, so reviewing your nomination packet, we know you from the Young Men's League of Guam, from your work on the Ancestral Lands Commission, but also from your work with the Farmers Co-op, from the Northern Guam Soil and Water Conservation, from Amit Farm. You're very active and engaged in our community. And so I wanted to ask about your approach to any of the decisions that the commission will make regarding land use restrictions. As someone who works in the field, where do you think the balance is between protective policies like restrictions of what can be built and development of land is?
Yeah, I'm very deep with the environment. As I was one of the leaders on the Scuba Spear Bill. Yes. And a member of the Soil and Water Conservation. Yes, everything has to come into a balance. And with regards to the environment, it is very high with me that I take it very seriously with regards to our waterlands, our soil, and everything that we do to our motherland. And we just have to make sure that it's done correctly and fairly, and that there is a balance that and we need to get accurate information and make sure that when we do make such decisions, that it is good for the entire people of Guam. And that's how I always look at it. As a matter of fact, like I said, I am an heir of my family has Teton property, 14 acres, and it's on the runway. And having served in the commission, I still have no way in trying to get that balance in there. I'm a member of the board, but it's still unjustly not giving back our properties, whether it be monies or land returns. But yes, I am so deep with the environment and then the protection of our resources, our natural resources. And we just, like I said, we just got to keep it, make it balanced so that everyone can be given the opportunity to grow and become well-being in our island.
Thank you so much, Mr. Laguardia Sidus Masi, and thank you, Madam Chair, for the opportunity.
Thank you, Senator. Senator Torres is here. Senator, you're recognized.
Sidus Masi. Sidus Masi Ron esta no kabalis todo in sangani ang pagunahani.
Sidus Masi.
Tata malago na be faisen holo. Malago na be singot be olakat na usen agradeci I servicio sa todo I bidada mo parita tauta giguahan. Sa bonito I funit tomorrow no agon of bonito lingua hita. Sidus Masi Ron. Sa binayaw I supporting.
Sidus Masi, Loki, Senator.
Senator Castro, you're recognized.
Thank you, Madam Chair. No questions for our brother Ron there, but I couldn't be more pleased to see Echelu as Ron Laguardia reappointed to such a position. As we can all acknowledge, he's a respected member of this community for his work in perpetuation of our Chamorro language and culture. I also want to state for the record, because you couldn't say it enough, that he's a warrior of past battles, intellectual, spiritual, and in principle, support, defense, and advocacy of our indigeneity in advancement of this great Chamorro nation. And frankly, for the record, I've drawn a lot of strength and counsel from Brother Ron. Sa membuhit na gi inet nun lalahing guahan. Sidus masilo kwit melu, pudi adzino mensenemu. We have a lot of memories with the late senator, also a champion of our Chamorro rights, the late Senator Angel Santos. Tunanas ikariranya, mek goods and tatdung I hiningenya, pudi manyamoruhit gitanamami, kilis jonu estinatseluta. The spirit is alive and well in this nominee, masas pashat giningguidza. And I rise in full support, unqualified, irrevocable support of this gentleman's appointment and confirmation. Thank you.
Thank you, Senator. Legislative Secretary, Senator Shelton, you're recognized.
Thank you very much, Madam Chair, and Hafide, Mr. Laguardia, congratulations on your reappointment. I think all the things about you and your resume have already been stated. A very impressive resume, a retiree of Guam, a Chamorro language master and teacher, and a farmer, a fisherman, an environmentalist, so many great things that I know you will continue to bring to this board. And so I want to thank you very much for the work that you will continue to do and that you're committing to. Obviously, even as a retiree, you are still a very busy man. And I was glad to hear your answers to Senator Regine Lee's questions, that you have the time and you have the commitment and the passion, especially to continue to do this. So Siduas Masi to you.
Senator.
Thank you, Senator. Senator Taitigui, you're recognized.
Buenas, John Hoffaday.
Hoffaday.
I like your smile when Roland, always enjoy your smile. I've known you for many years, your family. We go back, I think it was Anita and I that went to school with you, my sister Anita at JFK. I was GW.
Yes.
So, but I know your family very, very well. Roland, did you ever play music? You didn't, right? Because the whole family did. I didn't know if you did.
No, what happened
You're
was
the only one that didn't, right?
Yeah, I chose drums, but my dad didn't say. He said that drums was not an instrument. So what ended up was all my brothers, all 9 of them played instruments, and I got fond. My dad played every single kind of instrument. So hearing all of them, right, I ended up being the lead singer. So all of them now are playing instruments, and I come up and I sing. And most importantly, I sing Chamorro music.
Yeah. Even your sisters, actually. Don't forget
Yes,
your
all of them.
sisters. Dev plays
All-
piano and them guys. Yeah.
Yes.
So,
And
and
drums
I'm so
too.
happy, Roland, you're still being very active and,
Yes.
greatly appreciate you being very vocal about, our lands, our waters, the environment, our people, our culture, everything that identifies who the Chamorro people are. I greatly appreciate it and appreciate your balance, you bringing balance to issues surrounding the Chamorro, Guam Ancestral Lands Commission. There's definitely have to be a balance there. And I think you bring that to the table and every endeavor that you've tackled. So again, I thank you. Just wanted to thank you, Roland, and my very best. Happy holidays to the family. Please give them my very best as well. And thank you. Thank you for your service, Roland. Don't stop.
Yes.
Keep going. You got many more years ahead of you.
Mhm.
Many more. It's that.
That's
Sijus Masi.
Masi. Was it Madam Chair?
Yes.
And Kinsinia. I wanted also to let you all know that, I was also a tour guide for over 25 years. I worked for Discover Guam. So I have experience in tourism industry. I also managed the University Manor condominiums for over 16 years in Manila. It's a 57-unit condominium. I managed that as a superintendent of that facility. So I have broad experience in all areas. So I see a lot of different scenarios or situations. I deal with a lot of people of all races, and I learn a lot of different languages too by respecting other different cultures. So I have speak a little bit of the Palawan language and the Tagalog language a little bit. I just throw it in because when you use those languages, it makes them feel that you welcome them into our community. So I've learned to adapt and acculturate with other cultures. Thank you.
Thank you, Ron. And so thanks to all who are testified today. And again, Mr. Lagogne, I just want to thank you for your willingness to serve again on this commission, to move it forward, and for all the work that you have done to move it forward all these years. Most of the claims that were pending are resolved. And now it's our bigger issues that we need to really resolve. And so thank you again. There being no further testimony, we'll consider this appointment duly heard. The time is now 9:45 a.m. Sijus Masi. So all those here for the appointment may excuse themselves, and we will move forward with the public hearing on Bill 388-35 COR. This bill was introduced by the Vice Speaker, Senator Talina Nelson. She's not able to be with us here today. She's currently serving in an active duty capacity with the National Guard, but has asked the committee to proceed with this public hearing and has provided us with a sponsor statement on the bill. Right now, we will have Mr. Adam Suharto from the Vice Speaker's office, who will read the sponsor statement on this bill. Adam?
Afternoon and good afternoon, everyone. My name is Adam Suharto, and I'm a research analyst for Vice Speaker Talina Nelson. And as we know, Vice Speaker is currently on active duty with the Guam National Guard. So this statement is submitted on her behalf from the Office of Vice Speaker Talina Cruz Nelson. So the Guam Prescription Drug Monitoring Program is used to detect and prevent the misuse, abuse, and diversion of prescription drugs that are categorized as controlled substances. Data that is dispensed by pharmacies and practitioners is collected, monitored, and analyzed to provide patients the appropriate treatment and management of their prescriptions. The PDMP monitors controlled substances that are defined by state and federal controlled substance laws, ranging from Schedule 2 to Schedule 5, that contain opioids, tranquilizers, stimulants, or sedatives. Guam PMP Clearinghouse is the database infrastructure used to store data that pharmacies upload, which is managed by the vendor Apris Health Inc. Guam maintains full ownership and control of the collected data. The data collected is the prescription history information of all retail pharmacies on island and is submitted twice a month. In recent years, Guam's PDMP data shows that there was a growing number of prescriptions, quantity, days supply, or total MME, which stands for morphine milligram equivalent, for certain controlled substances. Among the top 3 of the most prescribed between 2015 through 2019 include alprazolam, which is sold under the brand name Xanax, oxycodone, acetaminophen, and acetaminophen, which is codeine. Studies show that the likelihood of long-term opioid use increases sharply after taking the 3rd and 5th day of prescription. The practice of increasing drug prescriptions exposes hundreds to thousands of patients each year to unnecessary risk of addiction, overdose, or relapse. Other risks to the community include the potential to collect vast quantities of controlled substance medications that go unused, building up a deadly reservoir of drugs at home that often wind up being unused and abused. In addition, it must be recognized that regular prescribing practices of opioids for relatively mild pain conditions, including lower back pain, muscle strain, and headaches, should be substituted with existing local and federal laws and regulations, management, and disclosures are necessary to ensure transparency when accessing prescription information from different healthcare facilities and providers. In order to support clinical decision-making by all healthcare providers, prescriptions must be controlled by requiring enrollment of prescribers to the PDMP. This requirement would ensure that the data is reported by dispensers and prescribers, which will enable more information to be collected and reviewed in regard to prescription drug management. Prescribers should also be limited to administer a non-refillable 7-day supply with a required review of the patient utilization report at least once every 3 months. This requirement would enhance the review and knowledge of both parties to see if the drug is necessary for any further treatment. This also potentially restrict patients from doctor shopping regarding the quantity and inform them of risks associated with prescribed controlled substances. Currently, 17 states have passed laws that require medical practitioners to discuss addictive potential of scheduled substances and found promising results. Studies show that prior to enactment of similar measures, only 18% of patients are warned about the risk of addiction to opioids. After enactment of similar measures, 95% of patients were routinely warned about the risks. And months after similar measures were enacted, nearly 5,000 patients were prescribed treatments other than opioids. So failure to obtain and review a patient utilization report and failure to advise the patient regarding the quantity and risk associated with controlled substances may be deemed appropriate for suspension or revocation of registration with DPHSS. In the healthcare industry where patient consultations are measured in minutes and time pressure in emergency rooms and surgery units is intense, it's often easier to prescribe pain pills rather than engage in discussing pain management. However, engaging in this discussion would enable practitioners to be more vigilant of controlled substances and give their patients more information in their healthcare decisions. An exception of such requirements should not need to be applied only to treatments that relate to pain management and dialysis or cancer treatments. Ending substance abuse and addiction as well as prescription overdoses requires us to do more to take on the social illness by starting at the source. A prevention measure that we know will work is to curb the overprescribing of opioid painkillers and other addictive controlled substances by ensuring providers discuss with patients the potential of addiction and by having their patient utilization report reviewed regularly. It is important to work to ensure that everyone who receives a prescription of a controlled substance understands the potential outcomes. With the surge of prescription diversion and substance abuse anticipated due to the COVID-19 pandemic, providing patients with life-saving information would be a strong step forward towards addressing the opioid epidemic. These are simple but extremely effective steps that could save many lives. On behalf of Vice Speaker Nelson, we look forward to hearing your voices and offer you our sincere thanks. Thank you for letting me share. At this time, our office has made aware of concerns from some members in our medical provider community. We are open to hearing your concerns with room for consideration of amending the bill as necessary. We welcome members of the medical community to send written testimony to Senator Terlaje's office as well as Vice Speaker Nelson's office. Thank you so much.
Thank you, Mr. Suharto. Again, he was reading a statement from the Vice Speaker Nelson, who's a sponsor of the bill. This is the sponsor statement introducing the bill. I want to thank again my colleagues who are here today for this hearing, including the Legislative Secretary, Senator Amanda Shelton, Senator James Moylan, Senator Mary Camacho Torres, Senator Regine Bisco Lee, and Senator Tello Taitiki. So thank you all who have been waiting patiently for this. All right, so as Mr. Suharto said, over the weekend, I was also worried. We had sent notices, of course, in accordance with the open government law, which was published in the Daily Post, sent by email, and it was sent to all senators. We also sent it to the Pharmacy Association and the Pharmacy Licensing Board. And over the weekend, because I was thinking I hadn't heard from many people regarding the bill, I sent also to the Guam Board of Medical Examiners, the Guam Medical Society, and the Guam Medical Association, and asked them to help me to get it to their members. So we have been asked this morning for more time to consider and submit testimony on this bill, and we could consider having another hearing during evening hours. And I will discuss these concerns with the sponsor, of course, and our goal is to get maximum input so that we can do something good. All right, so we've got several people signed up to testify, and I'll begin. Dr. Shea, is Dr. Shea here? I think he was, all right. Okay, so Jerry Caruso from the Guam Board of Examiners for Pharmacy.
Good morning.
Jerry. There you are. Thank you.
Okay.
Yes, you may proceed.
Is regarding the legislation. First of all, thank you for inviting me. Let me make sure it's understood that I have to speak as an individual pharmacist, even though I am chair for the Guam Board of Examiners for Pharmacy, but the entire board is not meeting regarding this. I can speak from my own personal experience, having lived on Guam for more than 27 years and practicing pharmacy that whole time. So my comments express my own personal experience and my profession. Let me start by asking if you had any personal, any question to ask.
No, I don't have any questions right now. If you have anything you'd like to say, otherwise you can wait and we'll, after the testimony of everyone, we'll see if any of the panel has questions.
Okay, I'd like to make a comment. I've read the legislation, at my copy, and it's pretty good. Practitioners who prescribe medications, including controlled substances, have always been able to sign up for the Guam Prescription Drug Monitoring Program. And I don't know how many of them do or have signed up for that ability to look at the history of their patients. But if you're making it a requirement that they take advantage of the PDMP, I think that's a very good thing. They can access pertinent information on over the last 1 to 2 years for any patient who comes in either seeking medications, controlled substances, or if they have any reason to prescribe controlled substances, they can look at the patient history. I think that alone would go a long way towards making sure that patients are not doctor shopping, or in the case of pharmacies who sign up for the PDMP, that you can check and make sure that your patients, your customers are not doctor shopping or looking for multiple pharmacies to fill prescriptions. And I think that's enough for me.
All right, thank you, Mr. Caruso. Dr. Cabrera, Dr. Felix Cabrera.
Hi, thank you, Senator. I actually wasn't signing up to give testimony. I'm just here to listen, and in case there are any questions or inquiries that occur, I'd be happy to try and help answer
All
them.
right.
Thank you.
All right, thank you. Dr. Nathaniel Berg.
Sorry, mouse trouble there. Okay, first, so Mr. Saharto, I'd like you to extend our appreciation for the Vice Speaker putting this, basically pushing us to do something, I guess would be the right way to put it. By having this there, we are now, if you will, forced to make sure we put this back in the agenda. I do think it's important for people to kind of understand first, let me also just, Madam Chair, thank you for giving me the opportunity to speak. And Senator Torres, Senator Moylan, who else do I have? I want to make sure I don't miss anybody. And Senator Regine Biscoli. Did I get everybody? Thank you also for taking time and expressing an interest in this bill. So I think I'm not going to talk in a long diatribe because the chairwoman has also indicated that we've already expressed our desire to have further meetings so as to provide input. This was on our agenda to take place in the first quarter of this year. This is both with the Guam Medical Society as well as or Guam Medical Association rather, and the Guam Board of Medical Examiners. The Federation of State Medical Boards has this as one of their top 3 priorities. And we can go over the other ones later, but this is one of the top 3 priorities. And for those who may not know, the Federation of State Medical Boards is the overseeing organization for all state medical boards. That's both DO and MD boards across the country. Clearly, there's a national crisis, and the history of it is something that I think people may not understand. And I'll give a very short history of that, and then talk about the bill and where I think we ought to go with it. When I was in medical school, there was a change in how opioids and pain were dealt with. And we were told that one of our vital signs needs to be a pain level. And we were also told that there was no real danger of addiction for short-term use of opioids, and that we were under-treating pain. It was emphasized to us in medical school, we're under-treating pain. And so those of us who sit, say, between the ages of about 45 and 60, who trained during that period, that's what we were told. Don't let patients have pain. And that is, by and large, what led to the crisis. It's Anthony Fauci, who now is famous for something else, once said quite astutely that the opioid crisis was started by well-intended physicians. The majority of physicians who overprescribe are not doing it because they're making money off it. Sure, those outliers exist. We don't think we have any on Guam that are these little, pain mills that were selling, getting paid on the side. That's pretty much gone around the country. But there are people who are trying to help people with pain. There needs to be some education regarding appropriate management of pain, and that is going on throughout the country. But that reversal and recognizing the damage that all of us were doing by not looking at the cost benefit, that is not financial cost, but the cost to the patient versus the benefit of alleviating the pain. We all, as physicians, have come to understand that balance is difficult. It's extremely difficult when patients are in severe pain as to how to handle. And the education of that is important. Now, as long ago as 2013, the Federation of State Medical Boards put out model legislation that should have a great impact. The problem is it didn't always come out. The impact was not always what was intended. And things had to be tailored to individual communities. And now there are, when Mr. Suharto mentioned that there are some certain number of states that require counseling. The problem is that data that he's talking about is old. And so that I don't think that there are many patients now who are not counseled regarding that. And the data that that was used to produce the 2013 model legislation is also old. Now we have a plethora of laws, rules, and regulations that were implemented around the country, and we have data to see whether they were impactful. So merely passing legislation, and this, I'm not saying that was the intent of the Vice Speaker, but merely passing legislation doesn't mean that we're going to have any improvement. And simply taking away someone's ability to prescribe based upon a specific set of rules and regulations is probably not the right approach. So in the latter quarter of last year, before COVID, we had an arrangement where in the first quarter of this year, we were already starting on it. The DEA, there's a woman who heads the DEA outreach to state boards and regulators to help craft rules and regulations that are effective and that have been shown to be effective. There are also members of the Federation of State Medical Board who are individual regulators, attorneys, and physician regulators, healthcare regulators, who have implemented effective policies. Ohio stands out as an effective policy that has nothing to do with what is in this legislation. I will give you one example and then tell you, I think that will help to understand why we need a lot more input, and the Federation of State Medical Boards and the DEA are absolutely willing to actually come to Guam. I don't know about tomorrow, but I think in the first quarter to help us craft that legislation that will be effective here. And I met with them when they were out here relatively recently. So the state of Ohio had tried various things that weren't working. And as some of you may know, Ohio was one of the hot spots, one of the worst places in the country with regard to the impact of the opioid crisis. What they did was they simply sent notices to physicians saying, you are in the top 4% of the prescribers for opioids in Ohio. And that's all they did every quarter. The first one they sent a quarter and said, you're in the top notice. We're not doing anything. We just want to let you know. If they did it again, if they were still in that top 4%, they sent them a second notice saying, hey, we want to let you know in this quarter, you're still in the top 4%. And if we just want to let you know, we may want to meet with you regarding this. had massive impact. It forced those physicians, and they would give them resources. It wasn't, I'm narrowing it down in the interest of time, but they gave them resources and said, you may want to look at alternative prescribing methods. You may want to look at getting continuing medical education in the field of pain management, of control. You may want to refer your patients to pain management if they weren't pain management physicians. So the impact there was great. And I think it may or may not be effective here in this small community. But there are loads of different models that we can look at and see if they could be effective in making change. Now, the other thing is, before we do that, I ask, and this is with all due respect, do we have an opioid crisis on Guam? Who's prescribing? Is it 1% of the physicians that are prescribing 50% of the medications? Do we find the data is there? I have not been presented with that data. And that was part of what the DEA and the FSMB, when they were coming out, they were going to work with public health at that time to collect that data. How would we know if this legislation is effective if we don't have data now as to how many people are prescribing how much? That data is very important to know what percentage of physicians are prescribing, et cetera, and looking at the specialty areas and the like. And there are really good criteria that would, for example, tell you if someone breaks a wrist, if they should or shouldn't be prescribed opioids. That data is there, those models are there. So I think that this is a good start and that it forces us to put this back on the agenda. But I would ask that when the Vice Speaker comes back, that we set a timetable for those things. What data to collect. I would love to work with public health. And I had included the director, Art St. Augustine, in our emails, as of late, that is, to re-engage. We're just so crazy busy with COVID and not having the ability to get people out here. And the Federation of State Medical Boards is also crazy busy with them. But I can tell you that the Guam Board of Medical Examiners has an extreme interest in this, in getting this under control and allowing input from everybody. I can also tell you that it's not that we don't have an effective system. We do. I will give you an example. So I wrote a prescription. Now this goes back 2 years ago, perhaps, or maybe even longer. I wrote a prescription for a patient for a very short-term use of opioids, very short-term. And I checked our system, that we can check the system already, checked it, didn't show anything. But the patient went to the pharmacy. The pharmacist called me and said, what's not in there is that the patient had a prescription at Navy. So when there is a system that allows for tracking of this, and I found out that that patient had already had a prescription at Navy that I couldn't see. So we went and tried to address that so that the system would show, it showed to the pharmacist, but it didn't show it to me when I looked into the system. So there are minor problems already with the system. I do believe that with Mr. Caruso, I believe he can tell me, but I believe that all the pharmacies are enrolled. And I also can tell you that we have a pain management specialist, and she can tell you that over the last couple of years, there's been a dramatic change in the way opioids are prescribed in a better way on Guam. So I think we need to look at what is the current situation. We need to look at robust physician and other provider education, as well as pharmacy education. Monitoring absolutely needs to be done. Notification policies need to be done. All of that stuff needs to be done. And that's my main thing. I think this legislation, I don't even think we need to, if you will, attack it or dissect it, or it'd be a better way, piece by piece, because I can look at it more as an extremely positive way of saying something needs to be done, even if it means at least looking at the data. I don't think it's possible that we will conclude that we don't have some degree of crisis, some degree. I don't know how bad it is. I don't think it's as bad as other places, but we need that data first, and then to make to set timetables, I guess, would be the best way to put it. So that is my respectful request that be transmitted to the Vice Speaker. And I also would make sure that when this is over, that the Vice Speaker has my email. Mr. Sajardo, if you could tell her she could use it, she can call us, she can, and I would even invite her to come to talk to the Federation, to talk with the Guam Board of Medical Examiners and move this forward. So again, I want to emphasize, I'm really not saying anything negative against the bill. I just want to have time to get all the input and make it as impactful as we possibly can. Thank you very much.
Thank you, Dr. Berg. And any the data that you are able to compile through the Board of Medical Examiners, if you could please forward that to our office, that would be helpful and as the committee acts on this bill. All right, we will be also hearing from public health and behavioral health in just a minute. So they might also be able to answer your questions. So we're going to, but hear right now from Dr. Vikawasi Niyami.
Hi, good morning. Thank you for having me in this forum. I really appreciate it. I'm new to this, so I apologize for my ignorance. But I wanted to say that as far as the opioid
Sorry,
crisis,
doctor, can you state your name and
I'm so sorry, I apologize.
information?
My name is Quasi. I'm a neurosurgeon, board certified here on Guam. I work at GMH and GRMC. I'm the chief of quality for GRMC, the vice chief of surgery for GRMC, as well as GMH. I'm also the chair of pharmacy and therapeutics for GMH. And that's sort of my position here on Guam. I guess what I wanted to say was, as far as the bill itself, I think it's a good start to try and address the problem we have here on Guam. The nature of that problem and the magnitude, I don't know. And that's because I think, as Dr. Berg talked about, the data is not there to quantify how big a problem this is. But I do believe that it is a problem. So one thing that we can do before we talk about a bill is to get data out to people involved in deciding what kind of bill to make. That way it will guide our hand as to how to address the problem. The second thing is, I think with any solution to a problem, we need to have education. And I think education of the community members and the doctors is important. When I say education, so as a neurosurgeon, one of the things that I see is back pain. I see it a lot on Guam. As a matter of fact, I'm the only neurosurgeon that's seen outpatient clinic for Guam. And so I see all the back pain. So these patients come to me on large doses of opioids, either Norco, oxycodone, OxyContin, some form of it. Most of the time, they have a reason for their back pain. They get the MRI and it shows that they have a disc herniation. One of the first things I do is I ask them, have you had physical therapy? Usually the answer is no. I ask them, have you had epidural injections? Usually the answer is no. These are things that can be done to help decrease prescription of narcotics to address their back pain. And so I think educating doctors, primary care doctors on Guam about some of the alternative modalities of pain management needs to happen, because a lot of doctors that treat back pain do not know that there's an option for physical therapy, which works. There's an option for epidural injections, which does work. And then first of all, there's an option for surgery. Prior to coming to Guam, there was a lot of mistrust in the neurosurgeon doctors here on Guam. I don't know why that is. I'm not going to talk about that. But since being here for the past 2.5 years, I've been able to speak and perform a lot of surgeries that have been successful and have gotten patients off large quantities of narcotics. So I think educating our physicians that, yes, we can address some of these back pain reasons why patients need narcotics and get them off narcotics. I think another issue is educating the community. A lot of the community members do not know that they have options for their back pain outside of narcotics. If you don't know what the options are, I think you're going to push your doctor to prescribe you narcotics. But if you're aware that there are options to treat your pain, whether it be back pain or other pain, then we can, have that discussion with the community members, and they can be more educated as to how they get their treatments. The next step after education would be programs. One program that has worked is something called the narcotic give back. Most doctors, once they prescribe narcotics, they usually prescribe more than what the patients need. And that's because as doctors, we don't know how much the patients need. So we can have a program where we tell the community, bring your narcotics that are not being used to the hospital and we'll collect it and we'll dispose of it. This will limit the amount of narcotics that's just flying around that people are using unnecessarily. There's also programs where we can educate doctors about how to appropriately treat certain kinds of pain. For example, we can have forums and different scenarios where doctors come and get CME on how to address back pain. I'm happy to have a talk about it because I've done it before in my past job in the States. But I think before we, vote on a bill and try and put forward measures, I think one, we need data. I think two, we need education. And three, we need to develop programs. By looking at all these three things, I think we can be in a better position to make an impact on the opioid crisis. Thank you for your time, and if you have any questions, please ask me.
Thank you, Doctor. I just want to read an excerpt from some of the research my staff did. So in August 2019, Guam joined a national lawsuit against Purdue Pharma, manufacturer of the opioid OxyContin, filing a civil suit in the Superior Court of Guam that cites alleged violations of the Deceptive Trade Practices Act under Guam's Consumer Protection Law, and alleges that Purdue misled prescribers and patients about the safety and efficacy of its opioids to increase the company's profits. Guam is part of settlement discussions valued at upwards of $3 billion, of which Guam will receive a portion. A.G. Camacho, the Attorney General Camacho, has publicly stated that Guam has an opioid problem and that data shows that 1,071 prescriptions of the company's opioids were dispensed on Guam between 2015 and 2019, and that there were more than 97,000 opioid prescriptions administered on Guam between that time frame. We were not able to independently obtain that data, but we will continue to pursue that. All right, so we now have we have representatives from the Guam Behavioral Health and Wellness Center. The director, Therese Areola, is here, and also Dr. Ariel Ismail, who is the medical director and psychiatrist. Director, if you could decide who's going to go first. Yes.
Madam Chair, thank you, Madam Chair, and good senators and everyone in this public hearing. Thank you very much for this opportunity. I will provide testimony on behalf of Guam Behavioral Health. I do have Dr. Ismail, and who is our medical director with me, and Ms. Queenie Fisher, who's our first full-time pharmacist at Guam Behavioral Health with me. Also, they will not testify, but if you have any questions, this is a collective testimony that was put together with their input on behalf of Guam Behavioral Health. And so if you would allow, thank you very much for this opportunity. Thank you, good senators, for being here. And I did submit testimony.
Yes.
Sorry. I did submit testimony this morning by email. And if you would allow, I can just read that testimony real quickly.
All right, it's up to you. And all the testimony for today's hearing has been provided to those on this Zoom via the chat. You'll see a link. So all the senators have that also. Thank you.
Thank you very much. Thank you, and Hafaday, Madam Chair, Therese Terlaje, good senators. Thank you for this opportunity to provide testimony on Bill 388-35 COR. After careful review and discussion with the Guam Behavioral Health and Wellness Center's psychiatrist, medical director, and pharmacist, Guam Behavioral Health unfortunately will not be able to support Bill 388 as written. We appreciate the author's intent to reduce the possibility of abuse of opioids. However, adding more administrative requirements for Guam Behavioral Health psychiatrists to adhere to will gravely limit the number of direct care time for patients to be seen by an already overwhelmed limited number of psychiatrists on staff. The concern regarding required patient utilization review every 3 months. In order to understand the negative effect of Bill 388 on the operations of Guam Behavioral Health, it's important to provide a brief background history regarding how our department has functioned in providing psychiatric services, which mainly provide medication and prescription support for the consumers we serve. Exactly 1 year ago, Guam Behavioral Health had 4 full-time psychiatrists and 1 half-time psychiatrist. Medication support and follow-up at the time was typically anywhere between 3 to 6 months for established and stable consumers, with all the psychiatrists having a full schedule of patients daily. Currently, the department has 1 full-time psychiatrist and 1 half-time psychiatrist, and has inherited and taken on the work of the 4.5 employees. The reduction of staff psychiatrists at Guam Behavioral Health is due to an unfortunate death, a resignation, and a recent retirement. The recruitment of psychiatrists is a challenge, but ongoing. The field of psychiatry already is limited to begin with, and its demand has become even more fierce due to COVID and its effect on residents. Guam Behavioral Health is actively recruiting psychiatrists year-round, and I am happy to report that we are in the process of contracting a part-time psychiatrist and are currently in interview with a potential prospect. Recognizing the difficulty of recruiting hard-to-fill positions, such as psychiatrists and psychologists, Guam Behavioral Health last year applied for and was approved as a designation site by HRSA. This designation provides those who wish to work for Guam Behavioral Health school loan forgiveness, a recruitment tool that is most welcomed. The current psychiatrists and providers in the department who are now providing prescription services to a population which was once being provided with follow-up care by 4 full-time prescribers and one part-time prescriber will not be able to comply with a 3-month utilization review and follow-up of patients who are on controlled substances, which will include the stimulant medication of Schedule II medication for ADHD treatment and benzodiazepines, which are Schedule IV medications for anxiety disorders and conditions with aggressive and suicidal behaviors. Unfortunately, if Bill 388 is passed into law, then the current prescriber at the agency will have no choice but to resign rather than work under the conditions which will be detrimental to them professionally. In addition, the difficulties in recruiting psychiatrist prescribers to work on Guam increases tremendously. They will not come to a setting where they will be unable to fulfill the prescribing requirements of controlled substances outlined in this bill until the preferred staffing level of 6 to 8 psychiatrists is in place. If this bill is passed into law, psychiatrists prescribers who do decide to take on this challenge will most likely make decisions regarding their patients not solely based on the clinical need and what is the best interest of the patient, but rather to meet the requirements of prescribing as required by law. Ultimately, in all the scenarios presented above, what will greatly be affected is the delivery of quality care for the population that Guam Behavioral Health serves. The concern regarding mandatory non-fillable 7-day supply. The controlled substances used by the department, which will be affected by Bill 388, include the following. Number 1, stimulant medication, a Schedule II controlled substance such as Ritalin, Adderall, and Vyvanse, which are first-line medication in ADHD treatment and mainly used in children. The initial non-refillable 7-day supply should not apply to stimulant medication. Once a decision to treat ADHD with medication is made, patients often will have to take the medication initially for at least several weeks to determine the effectiveness of the medication. The side effects, if they do occur, are often self-limiting, and patients will still be asked to take the medications for several weeks to determine if the side effects will resolve. The 7-day non-fillable fill will cause an unnecessary follow-up appointment to be set despite the short exposure time to the medication. During such a follow-up visit, patients and their caregivers will just be told to continue taking the medication for several more weeks. Such a follow-up appointment can have been utilized more efficiently for another consumer who may be having significant deterioration in his or her clinical status. Benzodiazepines, which are Schedule IV medication, such as Xanax, Klonopin, and Ativan, are used in treatment of anxiety and often used to manage aggression, violent behaviors, and suicidal behaviors of patients who have deteriorated clinically. Benzodiazepines are medications used in the treatment of psychiatric conditions, which causes very high anxiety levels or aggression. In treatment of individuals with high anxiety levels, suicidal behaviors, and aggressive violent behaviors with benzodiazepines, patients will also have to take these medications for several weeks before any decision regarding this medication can be made. A limited 7-day supply refill will have the potential of effective treatment being interrupted if a follow-up assessment cannot be provided within 7 days, leaving an individual without their much-needed medication until an assessment is possible. Also, the lack of flexibility in the initial number of medications that can be provided to the patient will only serve to further burden an already very overburdened health system. With regards to the pharmacy view, all pharmacists on Guam, including Guam Behavioral Health Pharmacy, are registered in the Prescription Drug Monitoring Program, PDMP, that is administered by the CSR, the Controlled Substance Registration, at the Department of Public Health, Guam Environmental Health Division. Guam Behavioral Health Medical Director and Nurse Administrator both have profiles with CSR that allows them to access and determine if a patient is being seen by other prescribers and obtaining other controlled medication from another pharmacy. Since the implementation of the Prescription Drug Monitoring Program several years ago, the days of doctor and pharmacy shopping is a thing of the past and has greatly provided safeguards to prevent abuse of controlled medication by patients. In closing, Guam Behavioral Health and Wellness Center recommends that psychiatry treatment be included as an exemption along with pain management in dialysis and cancer treatment. This will definitely ensure that psychiatrists are able to outline sound, quality treatment plans for the patients they serve. Thank you for your time and this opportunity to provide testimony on Bill 388-35. Undangklun na situas maasi. Thank you, Senators, for your time.
Thank you, Director Ariola, and I want to thank you for putting that in writing and in advance of the hearing this morning. So it's very easy for the senators to refer to each of your concerns. Thank you, and so thank you to the Behavioral Health and Wellness.
Thank you, Senator. Madam Chair. I think it'd be remiss if I don't mention. I heard Dr. Berg and many people, Dr. Kawasi, talk about data. And the information that I'm providing, I did not add, but I could amend the testimony. But for the record, I would just like to share that drug and alcohol services at Guam Behavioral Health, you folks know, New Beginnings. 80% of our addiction on Guam, the drug of choice is meth. We are dealing with a huge meth issue on Guam. About 15% of the services we provide is on opioids. And so at least on the service side and those seeking help, we're seeing that opioid is far less an issue than meth is on our streets and with our residents. And so maybe that is a little bit of perspective, at least on the service side, that it's really meth that we need to control on the island. And not that there is no issue of opioids. Again, we do have folks coming in seeking assistance for opioid addiction, but it's far, far less compared to the meth pandemic that we're dealing with our residents. So thank you for that.
Thank you. When you say 15%, if you're able to submit any additional data, that would be very helpful. Yes,
I will. Thank you.
We also found that Guam Behavioral Health had received $630,500 in federal grant funding last year from substance abuse and the SAMHSA, right?
SAMHSA, correct.
Specifically to combat the national opioid crisis. And it went towards New Beginnings, where you said before, that meth is a predominant issue.
And so,
yeah.
Right. And so for the record, yes, the federal funding that's coming down is specifically written as an opioid addiction, for opioid addiction, but it does not limit it to other addictions. And that's what we've been using at DNA, at New Beginnings. And so it's not $600,000 just for that 15%. It's $600,000 for everything. There is no limited, even though opioid was the purpose of the funding that was created by Congress.
Right. And maybe if you could just send us the data that you submitted for that grant so that we're all consistent. Okay, thank you. And I'll share that, of course, with the medical and pharmacy associations. Yes. Okay. So next we will have the Department of Public Health and Social Services. We have with us the acting Chief Environmental Public Health Officer, Jeffrey Pinala. We also have the program manager of the Prescription Drug Monitoring Program. But also, sorry, I'm wrong. I want to introduce Dr. Rosanna Robago, the Department of Environmental Health, Acting Chief Environmental Public Health Officer. Also with her is Officer Jeffrey Pinala, who is the Program Coordinator for Program Manager of the Prescription Drug Monitoring Program. All right, so Ms. Robago, thank you for waiting. You're recognized.
Thank you, Madam Chair. I have our testimony for Bill 388-35 core, and I'm here to present testimony on behalf of our director. So we did prepare written testimony and we did provide it to the office, so thank you. Half-a-day Chairperson Therese Terlaje, members of the Committee on Health, Tourism, Historic Preservation, Land and Justice, Senators Lee, Senator Moylan, Senator Taitigui, Senator Shelton, and Senator Therese. My name is Rosanna Robago, Acting Chief Environmental Public Health Officer of the Division of Environmental Health. I am here to present testimony on behalf of Director Arthur Sanagastine of the Department of Public Health and Social Services. Thank you for the opportunity to present testimony on Bill 388-35 relative to the registration of prescribers to the Guam Prescription Drug Monitoring Program, enforcement of the Patient Utilization Report, and the required disclosure of potential risks, and to provide an option to fill for a lower quantity prescription. So within the Division of Environmental Health, we have two programs related to controlled substances. The Controlled Substances Program of the Division of Environmental Health out of the Department of Public Health and Social Services is responsible for administering the Guam Uniform Controlled Substances Act, which is Title IX, Guam Code Annotated, Chapter 67, relating to the manufacture, distribution, and dispensing of controlled substances. This program is mandated to set standards for the control of prescribing, dispensing, and administration of pharmaceuticals by healthcare providers, as well as its distribution of pharmaceuticals by healthcare facilities like hospitals, clinics, or long-term care facilities, as well as other entities like manufacturers and distributors. The second program we have is the Guam Prescription Drug Monitoring Program, and we've heard that program being mentioned by some of the testimony we've had already. This program, the PDMP program, is responsible for maintaining the Prescription Monitoring Program, or PMP, which is actually a database that's dedicated for collecting dispensation records and providing training for providers on how to use the Prescription Monitoring Program to obtain a patient utilization report. Annually, since 2015, the Guam Prescription Monitoring Program collected an average of 49,000 dispensation records. However, only an average of 11,000 patient utilization reports is generated from the same time period. This means that Guam's physicians, pharmacists, and other healthcare providers only view 22% of prescriptions written to patients. That's based on our records. It's concerning that 78% of all prescriptions recorded were potentially issued without viewing a patient's prescription history, which can adversely impact patient care. So based on the 2020 Prescription Drug Monitoring Program Training and Technical Assistance Center, or PDMP TTAC, it's an annual survey. Only Guam and 8 other states do not have laws requiring for mandatory registration mandates for prescribers to use the Prescription Monitoring Program. So many states also have penalties and sanctions written in that include fines, revocation, and or suspension of a prescriber's license if they fail to use a PMP. This information can be provided at the following website, which is www.pdmpassist.org. The U.S. Centers for Disease Control and Prevention reported that in 2018, 67,317 drug overdose deaths occurred in the United States, and 69.5% of those deaths involved opioids. On Guam, PDMP data reveals that about half of all prescriptions are opioids. The most prescribed opioid that we have in our record is oxycodone acetaminophen at approximately 30,000 prescriptions recorded, with over 425,000 days supplied and dispensed since 2015. Nationally, prescription drug abuse has reached epidemic levels, and with an average of 128 people dying per day in 2018 due to opioid-related overdose. Prevention and education are key in ensuring that Guam does not reach that same levels. This department recognizes that individual practitioners have a duty to ensure that controlled substances are prescribed in a manner and dispensed in a manner that takes into account the nature of the drugs being prescribed, established medical standards, and that there is a legitimate medical purpose for treatment. The department's controlled substances and prescription drug monitoring programs support the intent of Bill 38835 with the current language that includes requiring practitioners to obtain a patient utilization report from the prescription monitoring program. Bill 38835 seeks to require this report that it be obtained before prescription is written. And this is also recommended in CDC's guidelines for prescribing opioids for chronic pain. Currently, a practitioner who has a controlled substances registration in their primary place of practice will not need to have a second CSR, controlled substance registration, for the second practice, provided there are no pharmaceutical controlled substances that are being stored, manufactured, dispensed, or administered, and that the activity is restricted only for writing prescriptions. So again, if a practitioner has a second place of practice and all they're doing is writing prescriptions, then by our Guam law, it's not necessary for that practitioner to have a second controlled substance registration. And the same is also true for the U.S. Drug Enforcement Administration, where there is no need for a separate Drug Enforcement Administration registration. Bill 38835 seeks to replace this requirement by requiring a controlled substance registration at all locations where pharmaceutical controlled substance is manufactured, distributed, dispensed, or prescribed. While the department does not oppose this proposed change, we question the intent of this requirement, given that a controlled substance registration is not necessary for a practitioner to just write a prescription. Should this legislative body support the requirement of controlled substance registration for all locations that a prescription is written, then we would just like to point out that there are many references both in the Guam Uniform Controlled Substances Act and the corresponding rules governing the manufacture, distribution, and dispensing of controlled substances, which makes reference to the activity of manufacturing, distribution, and dispensing. So such activities would need to be revised to include the word prescribing in order to meet the spirit and intent of Bill 38835, as the amendments proposed in the bill are not and should not be limited to the sections 67.303C, 67304A, and 67308J, sections J, K, and L. One example is under Title 9 GCA Chapter 67, Section 67302A provides for the registration requirements for a controlled substance registration whenever a person manufactures, distributes, or dispenses of controlled substances. So essentially, throughout the different provisions, we would need to insert that word prescribing. On a similar matter, we are requesting, this is something different. On a similar matter, we are requesting that Bill 388 also include a provision to provide for the updating of the appendices A, B, C, D, and E of the Guam Uniform Controlled Substances Act, which is essentially the list of all controlled substances. The Controlled Substances Program is prepared to work with you and your committee in providing these updates as provided by the U.S. Drug Enforcement Administration, who has oversight in the list of scheduled controlled substances. And I just want to bring it to the attention of the Madam Chairperson that the last time we updated the schedules was quite some time ago through Public Law 31-110. So, you know, there is a definite need to update the schedules. And in conclusion, for the reasons stated above, this department is in support, Madam Chair, of Bill 38835. Thank you for the opportunity to provide testimony this morning.
Thank you very much to the Department of Public Health and Social Services for your Division of Environmental Health for that information. Very helpful. Okay, so there's still 3 more I've got signed up to testify. And so we'll go with Mr. Gary Schiff, and then Dr. Carla Haddock and Dr. Lauren Cabrera.
Good morning, senators, doctors, guests, friends, everybody on this call. Thank you for giving me the opportunity to give testimony as a patient rights advocate against this bill. And these are the points I want to make. It'll be fairly brief. First, I think there is some question whether there is a problem with prescriptions on Guam. I mean, no one has really given us that definitive information. And with the system we have in place, if it's not broke, why fix it? Every pharmacy on Guam, and Jerry can confirm this, everyone that dispenses a controlled substance is required by law to sign up with the Prescription Monitoring Drug Program. Every prescription is reviewed at the pharmacy to make sure that that patient isn't doctor shopping or being overprescribed. And the pharmacist has the right by law, under the existing rules, to deny any patient a prescription to be filled if they deem that there's anything weird going on. Okay, Jerry, is that true? I would say so. I'll get back to you later. Okay, so that's the point I want to make. Number one is that we have a system. The system works brilliantly at the pharmacy. That's the firewall. You can't get past it. It's impossible. They bring up all your data. They know exactly what prescription you have filled. They know the date. They won't refill it if it's sooner than 30 days. They are the stopgap, and it's working. Now, secondly, as a patient rights advocate, I trust our doctors. I know every one of you here has their own personal physician who they've seen for many years, who we trust with our life. I do. I think you would all agree with that. We have the best physicians. We have the best pharmacists too. Jerry, I don't want to leave you out of that. They really are the best. Okay, so assuming we trust our physicians, why do we need to tie their hands and say, look, this is how you have to prescribe controlled substances? And really, we're talking about opiates more so than any other substance. Why should they be denied the patient-doctor right to decide how to dispense those medications? These physicians have many, many years of training. They're really good people. And this will create more paperwork, more time, more appointments. And just like the director of behavior mentioned, a lot of them will drop out and say, look, I'm just not going to prescribe. It's not worth it. It's not worth the headache. And then, this is the point that I really want to make. We know there's a lot of patients on Guam receiving controlled substances, whether it's opiates, sleeping pills, tranquilizers, anxiety medication. We know that, whether it's in the hundreds or the thousands. We've had opiates being dispensed on Guam since before World War II. So this exists. Now, all of a sudden, this bill gets passed and starts. Now, what's going to happen to all these good people that have been doing the right thing? They go to their doctor every month. They get their prescriptions filled properly. They have real medical issues, whether it's spinal issues or other serious conditions. And now the doctor says, sorry, we have to taper you off. I can't prescribe. What are these people going to do? First off, they might go through withdrawal. That's a given from many medications, particularly opiates, okay? Once they're through that, they still have the pain. So what are they going to do? They're going to look for other sources for pain relief. They'll look to the internet. Fentanyl, which is the most deadly medication on the market, may start appearing on Guam. They'll ask family members in the States, can you send me medication? You're leaving them no option than to hit the streets. We don't want that to happen. We have our doctors monitoring the situations. They know what they're doing. And we don't want to leave these thousands of patients. A lot of our older Minako who need these medications, all of a sudden, grandma's out on the street buying meth to fix her headache. Or, I mean, that's very extreme, but you get the point. It's just not the right thing to do. Excuse me. So these are the points that I'm not sure were considered, because we have a lot of long-term patients that are on opiates today, perhaps thousands. We can get those numbers. And they live a good life. They're in our community. They own businesses. They have families. They're doing the right thing. So maybe this bill could be amended to apply to first-time opiate users, or those that those would be exempt if you've been taking opiates for, let's say, 12 months or whatever. They would be exempt. So it would apply more to new-time users so that they don't get the problems that you can get with opiates. So these are the things I wanted you to consider. I think our pharmacies are great. That's the stopgap. That's the oversight. They're doing their job. Why fix it if it's not broke? thank you all for listening. I really appreciate your time. Thank you.
Thank you, Mr. Schiff. Dr. Carla Haddock.
Hi, good morning, Senators. I am testifying today both as a prescriber and as a consumer/mother. First of all, I do appreciate the intent of the bill. When reading it though, when I was reading the intent, I believe that we lump together opioid use and controlled substance use together. And we really need to separate those two. As you know, controlled substances, as many of our other people have testified, are opioids, stimulants, depressants, hallucinogens, steroids. And it's unfair to lump the opioid crisis with all controlled substances. Secondly, when I was looking at the intent and the reference CDC article, it dealt with chronic pain. There is a difference between acute pain and chronic pain, and there's a difference between acute on chronic pain. And I think to lump all treating of all acute pain with chronic pain is also wrong. Third, I have a serious problem with that 7-day initial non-refillable prescription, both as a prescriber and as a consumer. As a prescriber, I often see patients who come in with acute pain problems, and I start them on medication for a period of usually 2 weeks until I can get them back to see them and to reevaluate them. Post-op patients, I can tell you, need more than a 7-day supply. And having them come back to clinic is hard on the patients. I have dealt with postpartum mothers who have gone through depression and acute psychosis. And a 7-day supply is nowhere going to touch them. I have to have them on these medicines for at least a month to evaluate how they're doing, as Director Arriola testified. And finally, as a mother of a child who is an ADHD child and has been on Adderall, I cannot imagine starting my child on that medicine and then having to go back every 3 months for reevaluation. Especially in this pandemic when we already have a limited access to care. As a primary care provider, it is very hard to get access to our limited psychiatrists, as Director Arriola said. We are often faced with the burden of starting patients on medications and buying them time until they can get into such specialists. Having that 7-day supply will really limit us from providing the care that we need to provide. I also am unsure where we got this 7-day rule. It's a new section under section 5 on page 5. And if you look before it, all the subsequent under the GCA, it only says a 7-day in terms of not being able to fill a prescription that is greater than 7 days. It has nothing to do with only a 7-day. So I'm not sure where this arbitrary 7-day came out, but I can tell you as a prescriber, it's going to hurt my patients. Finally, there is a subsection or somewhere in the intent, and then on page 6 of line 2 to 3, where it exempts certain prescribings, pain management, or it says dialysis, cancer treatments, or other specified under subsection 67.308.2. I did look that up, and that basically just says those going through acute withdrawals in some kind of facility are exempt. However, I believe that there should also be an exemption for palliative and hospice care. Not all palliative hospice care patients are cancer patients. And I know my other colleague, Lauren Cabrera, will address that as well. And as Dr. Arriola said, for our psychiatric care. And I believe that we need to look at that. I do want to applaud our physicians, our pharmacists, and the drug monitoring program. I do have access to the PMP Aware website. I do, in the ED mostly, when I see patients, do look up their profiles to make sure that they're not drug seeking I do less so in the primary care setting when there is an acute reason that I can identify, or in the postpartum setting, or in the post-surgical setting. I do feel that we're on the right track, but I kind of questioned the timing of this bill and the intention of it. I don't believe that it needs to be implemented at this time without the further research, as Dr. Berg and Dr. Naomi said about the opioid crisis on Guam. Also, in regards to the CSR that was brought up by Rosanna Robigo, if we were to get a CSR for every location that we prescribe at, I personally have several part-time jobs, and I would need to get 3 or 4 different CSRs depending on where I work. And as you know, the fee increased dramatically from $120 to $500. That's over a 300% increase. And that would mean I'd have to fork out about $2,000 to prescribe at all the different places that I work. And this is so far much more than my 5-year DEA, which only cost me about $700 something. So I really think that that is a huge detriment, and people are just not going to want to prescribe these controlled substances because it would be a real burden on us. Thank you.
Thank you very much. Dr. Lauren Cabrera.
Hi, good morning. Thank you for bringing attention to this important issue. My name is Lauren Cabrera. I'm a nurse practitioner working for GRMC, and I specialize in cancer pain management and palliative and end-of-life care. I completed a fellowship in this specialty at Memorial Sloan Kettering Cancer Center, and I'm the only fellowship-trained palliative care provider on island. For those of you who are unaware, palliative care is the care of patients who are seriously ill and suffering from illnesses that negatively impact their quality of life. Often these are terminally illnesses, but not always. While I understand and fully support more stringent control of opioids for patients who are at risk for abuse and misuse, I want to take this opportunity to address issues with opioid access that causes unnecessary suffering for my patients who really need these medications and are already suffering so much. I'm here today to speak on behalf of these patients because there are a lot of issues with them obtaining opioids on Guam. I would like to shed light on this. Every time I prescribe these medications, my patients must come to my clinic to pick up a paper script from me because we're not able to e-prescribe opioids on Guam. This is difficult enough for my patients who are frail and seriously ill. On top of this, there's a huge opioid shortage on Guam. My patients often have to come to my clinic several times a month to get their script because I can only give them a couple days or a week's supply of these medications. And they really need these medications to get through like day-to-day living. If they don't have these meds, often my patients will end up in the emergency room, and I'll get calls from the emergency room physicians wondering why my patients are there. And it's just because we called a lot of pharmacies and we couldn't find the medication they need. Every time I prescribe an opioid, I have to call multiple pharmacies. Jerry can attest to this. And I have to figure out who has what opioid. Sometimes I have to change their medication like halfway through the month, and then I'll change it back the next month to what they were on before. And this results in the loss of valuable time and resources on behalf of the providers. But if we don't do this, then these really sick patients who don't feel so good have to go visit 5 or 6 pharmacies looking for their medications, which is really hard if you don't feel good. I'm tired of my patients running out of these medications due to low supply, or because they feel too sick to come to the hospital to get a prescription from me, or because maybe they live in Agate and they don't have a car and nobody can drive them to get their prescription for the 3rd time this month. I understand and support the limitation of controlled substances for some patient populations who are more at risk for misuse and abuse, but I'm taking this opportunity to plea for less limitations rather than more for these cancer patients and other end-of-life patients who really need these medications. Please ensure that any bill introduced specifically and clearly exempts these patients from any limitations to their controlled substances, which are necessary to prevent their suffering. We should also consider adopting e-prescribing for controlled substances as a way to increase access to care for these patients, so they don't have to come to the hospital all the way in Dededo and pick up a prescription from me 3 or 4 times a month. Many states have already mandated that all controlled substances be prescribed electronically. This is a much safer and more effective way of prescribing these medications. In fact, the Support Act, passed in 2018 to address the opioid crisis, requires there to be electronic prescribing for controlled substances in the Medicare Part D program beginning in 2021. Help Guam to get ahead of the curve with CMS compliance while improving patient quality of life and safety by adopting the electronic prescription of opioids. I think this would help my patients a lot. Thank you.
Thank you, Dr. Cabrera. All right, so we're now going to allow questions from the panel. All right, I'm going to ask one of the Department of Public Health, Ms. Rubago, if you could describe what is the gap that you see in the, if for example, all pharmacists have to avail themselves of the program. They have to look it up before they issue the opioid to a person. What is the gap that would be filled by requiring the doctors to look it up at the date of prescription?
Thank you, Madam Chair. I hope you don't mind if I ask Mr. Pinaula, who oversees the prescription drug monitoring program, if he could answer that question.
Sure.
So currently, we only have 364 unique physicians, healthcare providers that have a controlled substance registration, but only 37 are registered to use the PMP database to look up a patient. So that is one of the gaps right there, where we don't have all physicians on Guam with the ability to look up or view the patient utilization report. I do provide training. Using the PMP is fairly easy. It's as simple as doing a Google search. You just have to register with us, and yeah.
Yeah, but my question is, if the pharmacists are required and all pharmacists are signed up to do these searches before they issue the actual drug, what are we trying to accomplish by requiring physicians to also look it up in advance of the pharmacy?
I would say for better pain management, view their history. But also I want to note that based on the current law, pharmacies are only required to upload their dispensation information. They are not required to look up a patient based on the law. They can, but they are not required. And just based on the data I have that we shared in our testimony, only 22% of all prescriptions written or 22% of patients have reports generated by either a pharmacist or a physician.
Okay, so
that says not all pharmacies and look up a patient.
All right. Okay, that's what I wanted to know. And what if the bill was amended to just require all pharmacies to do that and not require physicians to do that? Would that cover all potential gaps or not necessarily?
I don't want to speak for a physician's practice and how their prescribing methods are, but I think it can just give an additional information for physicians on their patients' history.
oh no, I can definitely see the benefit of physicians doing this. Yes, between them and their patients, of course, and management. But I'm just looking for abuses, right? If we want, but all right, I understand. Okay, I'm going to open up to the panel. We've been all here for a long time. So Legislative Secretary, Senator Amanda Shelton.
Thank you very much, Madam Chair, and thank you to everyone who's here to testify today. I really appreciate all the perspective and learning from each of you. I'm not sure who can best answer this, but for learning today about the prescription drug monitoring program and it being available to providers, healthcare providers, as well as pharmacies, can someone share a little bit about why a provider may be hesitant to sign up for it or has no interest in using it?
Just based on some anecdotal information, and when I attend national meetings, a lot of it is just that extra step they have to take to access another database to search a patient when, you know, time is of the essence when you're meeting with your patients, and, you know, but there are ways to integrate the prescription monitoring database into a clinic's electronic health record. So if they search a patient once, it'll show a score of that, you know, based on their prescription history. But that's another whole different story requiring a whole different monies to implement.
Okay, and the prescription drug monitoring program is a federally funded program, but for a physician to use it in their clinic, do they need to pay a fee?
No, they don't. It's free to use for any physician or pharmacy.
Okay, thank you. And I heard the physicians today in the hearing speaking about the need for data as well as from behavioral health. And I know that we're constantly being told about the methamphetamine use on Guam. So I think that's something I was really looking forward to hearing about more data about the use of opioids and prescription drug abuse that I don't think we heard enough about today. So I'd like to further see that data before we can move forward on this bill to build consensus, because we heard from so many different people today that there's a lot of work to be done here. So I really appreciate it. Thank you very much, Madam Chair.
Thank you. So by the way, yes, public health, if you have any of that type of information, if you could provide, if you believe what the problems might be on Guam based on data.
We do, just real quick, we do have a
please.
dedicated database for that that analyzes all the prescription that is uploaded to our database. If doctors or physicians or anyone needing that data, they can just submit a request to our director, and that will get to me, and I'll work with that individual to for that data. It's all de-identified, so there's no personal information.
All right. Are you able to make an assessment from your data whether there is an opioid crisis on Guam, I guess? Or you said that we have not reached the levels of the state and the other states. In your testimony. You said we should ensure that Guam does not reach the same levels, which you described nationally. How do you, so how do you determine what level we are at?
Based on deaths, I'm not too sure. My system does not track opioid-related deaths or deaths for that matter. But just based on prescriptions, half of prescriptions since 2015 are opioids, and half are non-opioids. So that's an indicator there that we are prescribing a fair amount of opioids, about half of prescriptions.
All right. Well, if you have anything that gives us guidelines as to what we should look at that data and compare it to. All right. Or any of you, if you could send that to us, I'll share it with all the senators. All right. And so now Senator Moylan, is he here? Senator Moylan, Senator Mary Camacho Torres.
Thank you, Madam Chair. I want to thank everyone for a very well-rounded discussion today on this bill. What you shed light on particularly is the unintended consequences to patients and how that really needs to be the focal point here more than anything. I believe this bill requires a great deal of work and perhaps, could have been better vetted before it was even introduced, I think, because there are many issues, there are many levels to the opioid issue on Guam and to the prescription of opioid medication. But I don't have any particular questions. I'm very interested to see how this develops, but I especially want to thank Therese, Lauren, Gary, and Carla for bringing the other perspective, outside of the medical concerns, but the true ramifications of such policy on people who are terminally ill or have acute illnesses that need to manage in order to have a quality of life that, many of us take for granted. So I just want to thank you very much for your testimony today and greatly appreciate it.
Thank you, Senator. Also, if I could just ask for information regarding drug use of illegally manufactured fentanyl or other type drugs. This is when we research the opioid crisis. This always comes up, but I'm not able to find anything regarding that on Guam. So if any of you have that, please submit that also. Senator Lee.
Asidus Masi, Madam Chair. And I just also want to thank everybody for all the testimony. I learned quite a bit this morning from all of the perspectives that were shared. So I'm really grateful for everybody lending their voices and providing testimony on this bill. I also want to thank the author and thank you, Madam Chair, for the opportunity for all of us to come together and have this conversation. I'm really grateful to all of you for the work that you do to keep our community safe, to keep our community healthy. But I definitely would love to hear more. I know the chairwoman had asked DPHSS and others to provide additional information, particularly local data that can help to better inform the committee before moving forward. I do have one question for DPHSS, and this is with regard to information that was shared with Dr. Berg during his testimony regarding how in other jurisdictions they might send letters to healthcare professionals who prescribe opioids and controlled substances to let them know that they might fall in the the top 4% of prescribers for some of these, for either opioids or controlled substances. And I just wanted to see if that was something that is possible for DPHSS to accomplish, or if maybe you are already doing something similar to this. So if somebody from DPHSS could inform the committee about where we are on that particular option.
Thank you. Thank you, Senator Lee. I just wanted to bring up a point so that under our division, we have two programs, the Controlled Substances Program. That's the program I oversee. Mr. Pinaula oversees the Prescription Drug Monitoring Program. Our programs are separate and totally different from each other. The Prescription Drug Monitoring Program is intended to serve as more of an education, awareness, so that practitioners and pharmacies can better manage patient care. My program, the Controlled Substances Program, is specific intention is to conduct investigations or record audits of practitioners for controlled substances, or like if there's any diversion. So with your question, that's more in line with the Prescription Drug Monitoring Program. That's why I keep deferring to Mr. Pinaula. Okay, Jeff. So to answer, thank you.
So no, we currently do not do that. That is a possibility. We do have the data to do that. But as I'll also mention, there are states, and the system is capable. It it's another fee, I guess, but there is something called prescriber report cards that this the system we have that can be done, but it's another separate fee and whatnot. But yes, there is a way to generate prescriber report cards that automatically gets generated and sent to a prescriber just to inform them of their prescribing practices. When I went to the national meeting last year, there's kind of a 50-50, what you call it, some prescribers like it, other prescribers don't like it, or physicians. And so just based on the national meeting and the state's feedback on states that are implementing prescriber report cards.
Thank you very much for that information. And I just wanted to note for the record that I thought that that suggestion by Dr. Berg was an interesting one. I'm not sure if the chairwoman, wants to pursue something like that for DPHSS, but maybe that requires an additional conversations from all the stakeholders. But I just want to thank everybody for your participation and for your testimony this morning. Thank you very much, Madam Chair.
Thank you.
Madam Chair.
Mr. Caruso, yes.
Yes. Okay, after hearing a lot of the testimony so far, I think many people, lay people who don't work in pharmacies and many doctors and prescribers don't know exactly what's going on. Let me just give you a few bits of information. Only about half the pharmacies on Guam carry opioid or narcotic pain relievers, Schedule II controlled substance pain relievers. When it comes to how much the pharmacy stocks, how many different products and how much of each product they stock is limited by what's called a threshold. I know my particular experience ordering narcotics, if I run into the upper level of amounts that my pharmacy has used within like a 3-month period of time, the wholesaler simply won't fill it, even if I have a greater need for it. And the threshold can be increased, but it takes some work and some doing to get it done. Regarding patients who go from pharmacy to pharmacy trying to get the medication they need, if they call a pharmacy, most pharmacies on island won't entertain phone calls about controlled substances. This goes back to the day before we had the PDMP, the drug monitoring program available, and pharmacies had to use the Christmas tree phone calling system to find out if someone walking in with a prescription for a narcotic had been to other pharmacies. Now you can quickly look up that information on the PDMP. If they bring a prescription into the pharmacy and the pharmacist says, oh, we don't carry that medicine, then they find out then and there. If pharmacies would take, other pharmacies would take a little more interest in customer service, they could ask questions over the phone of patients who need narcotic medications to determine, what they need, who they are, what doctor is writing the prescriptions, and if you have it in stock. And if you don't have it in stock, you say, I'm sorry, I don't have any. In some cases, I say limited probably number of cases, they may determine they're just not interested in dealing with it. But pharmacies can do a lot to help customers in locating supply if they have to have it. But not all pharmacies will take the time to entertain the kind of questions I just described, or trying to help out customers by calling other pharmacies for them to ask. I've done this frequently enough. One other issue is the requirements by Department of Public Health, and this is directly related to Jeff Pinala's testimonies. I think pharmacies are only required to upload the PDMP files every 2 weeks. And I think that should be amended at some point to change to no less than once a week, maybe even twice a week, depending on the quantity of medications your pharmacy handles. I think even 3 times a week is not too much, just so that we have up-to-date information anytime anyone wants to access the PDMP file. Another issue is insurance companies. They change their rules and regulations frequently and usually without any notice. Some insurance companies have a 7-day limit on the amount of controlled substances a patient can get at any one time if they're a new prescription for a patient. In which case, it's okay for the pharmacy to fill less than the amount prescribed. If a doctor writes for a 30-day supply and that particular prescription is limited to 7 days, then you can fill it for 7 days only, or you can let the customer know that you may have to pay retail price for the full amount. But even so, all that information goes into the PDMP file. Those are some of the issues I wanted to make sure people were made aware of. Thank you very much.
Thank you, Mr. Caruso. Senator Taitagu.
Thank you, Madam Chair, for the opportunity to speak. And I'd like to thank you too for really reaching out to the community and the health community, as well as the boards, commissions, to be here today to provide testimony. However, I think the opportunity for additional testimony should be required. I think Dr. Berg mentioned hopefully that there might be another opportunity, or yourself, Madam Chair, to have another public hearing to go further into it. Because, I think the bill is, trying to be proactive more than reactive to something, because it's, even though the data is not showing a huge crisis on Guam right now, I think being proactive is a route to go. And some of the concerns too that were brought up regarding the bill itself, I too had some of those concerns, like the 7-day non-refillable provision is not even in an existing law. I think it was probably referring to the timeline in which to pick up your prescription, and so that is something in the law that I was confused about, because I too tried to look through the current laws to see that, and I didn't see anything, but only referred to the timeline to pick up your prescription. I'd also like to, if you can, Madam Chair, reach out to GPD as well, getting some data from GPD. Other private healthcare providers as well, of course, like they were here, or organizations that concern substance abuse, not just on the private, but the nonprofit organizations that deal with that. I think information from them would be very helpful as we move forward to address any concerns. But I greatly appreciate everybody's input that they brought in today, and looking forward to another public hearing to broaden the perspective of trying to create some kind of proactive approach to the opioid crisis. It might not be as predominant in Guam as it is in the States, but let's not get to that point. So thank you, Madam Chair.
Thank you, Senator Taitagu. And thank you again to all of you who testified today. If I could just clarify one thing before we log off, and that is if pharmacies all are required to have access to the drug monitoring system and program. They're all enrolled on Guam, and they are all required to update their information showing how much they've prescribed. But if they're not, and I heard this today, that they're not necessarily required to look up a patient's history or whether he's filled a similar prescription a week ago or 2 days ago at another pharmacy, And if they're not required to do that, is that the gap that allows for abuse? Or is it the gap that because they're not required to mandate 3 times a week right now, that even those pharmacies who are looking this up each time are not able to see it? Or is it that physicians are prescribing, for a patient a certain thing, and then I don't know if the patient's able to go to another physician and get another prescription for another type of opioid, and is that what's creating the abuse? I'm not really sure, but I want to know. There do seem to be some existing gaps if we're talking about overfilling prescriptions, or getting duplicates, or just getting access to too much more medication than the physicians intended. So as to those gaps,
Senator, if I could take that question.
yes, that's Dr. Felix Cabrera.
Yes, thank you so much. And so thank you for this moment here. Just wanted to take your question and then to make 3 really quick points. I really appreciate everybody's testimony today, and heard from a wide variety of opinions here. But to your specific question, which is actually one of the points I was going to hope to make, was that the prescription drug monitoring program, it's just a search query and for the providers really, and just to see and to cross-reference, existing prescriptions that were already filled by your patient that you're trying to monitor. Now, the key part here is that it's how do you use that overall. So let me take an example. When I used to practice primarily primary care, and I had multiple patients that were on chronic opiate therapy. And these were usually responsible people, but what we had was specifically what's called a narcotics contract. And so it's literally a contract that I have with myself and the patient, whereas we're going to agree to a chronic pain management, and these are the criteria. One of them is I may ask you at the time to do a urine drug screen. And if you seek a prescription from somebody else who is not necessarily covering for me, then then we broke our narcotics contract, and I will no longer prescribe you narcotics. But then that's where the prescription drug monitoring program comes into play, where we can randomly audit the patients that were on the narcotics contract. Now, this is not as useful for and practical for many providers that don't do this on a regular basis, or usually only do very short-term treatments and therapy. So that's been the challenge there. So and how that's used. So mandating that all providers be on that just so that they can query. I don't know if that really solves too much at all, because again, it has to be about how they practice and what they use that tool for. So that's there. The other quick point I wanted to make was that first of all, I applaud the authors of this bill and for being again proactive about this. I've had multiple discussions with Attorney General Levin Camacho and about this specifically. And one thing that we have to really recognize is that how actually fortunate we are here in Guam and the Mariana Islands, in that the opioid crisis is nowhere as bad as it is stateside. And here's why. The main reason why, so you talk about gateway drugs. Usually opiates is exactly that. This is the one where I actually agree there isn't a gateway drug. They get prescribed, they may get addiction tendencies with it. And then once they no longer get that prescription, or it gets too expensive to get that prescription, or two owners, they go to the quicker and easier opioid to get on the street, which is heroin. And so heroin is an opiate, and it's the one that actually is not prescribed in any way, and it's purely an illegal drug, but it's sometimes a lot cheaper and easier to get. And then that's where the crisis really explodes in that process. Or if they get other much dangerous prescription types like fentanyl, for example. So because heroin isn't as easily accessed here on Guam, there used to be a big heroin problem in the 80s, as I understand, but not so much now. I'm not saying it doesn't exist, but it's not a who are going to get prescription, that it has to be through e-prescription. And e-prescription is very much available in Guam. There's a clearinghouse that's available. And so it's easy to do, but Guam needs to be ahead and pass. So actually, I really encourage that this bill be amended to include e-prescribing. Right now, as it's written, the law is written, you can only do it on paper, and you can't be faxed or any transmitted in any other means. E-prescription has been shown to be actually extremely way more secure and less susceptible to abuse and manipulation than a written script. And also, it provides a very, a clear digital trail. And so that's the part there that's very helpful as well. And so that we can actually see that prescription going directly from provider to pharmacist and nobody in between. And so I think that can be very helpful. But it has to be, again, done with the responsibility of what this whole bill is trying to create. But of course, the special exceptions that have been pleaded here, I think, are very important. How do you incorporate those exceptions? Because let's be clear, majority of behavioral mental health is not practiced by psychiatrists and psychologists on this island. It's the primary care physicians on the island that do majority of it, and they actually prescribe medications. And so how do they actually get exempt? Because it can't be specifically by provider. And at the same time, palliative care provider isn't the only one providing palliative care. So how do we enforce that? And so that's the real question that we have to answer. And I don't have the answers to that right now. But thank you so much for your time.
Thank you very much for your testimony and your insight. Senator Moreland, questions for the panel?
Thank you, Madam Chair. I think the question will be directed to Gary. For the health insurance companies, they work with a pharmacy benefits manager, right? It's that company that administers all their medication for these different health insurance companies. Some on island have the same, they call it PBM. Some, I'm not sure, other insurance companies may have different, but there's a pharmacy benefit manager, and they're the ones that monitors, especially all these opioids, and alert the insurance companies if there is some abuse. And then it's also, I think it goes with Drug Enforcement Agency as well. So I'm wondering if you can just, Gary, if you can kindly explain, has this program, I think you mentioned it, some of it, but if you can reiterate, has this program been working? Have you actually had to stop a customer from getting the prescription medication because it exceeded the threshold of DEA or the PBM department? If you can just re-highlight that for me, please.
Okay. The pharmacy benefit manager, the PBMs, there are different companies that handle the insurances on Guam, the local insurances. And then we deal with Medicare and Medicaid. And Medicaid does not have a PBM that I'm aware of. As an aside, the Medicaid system could save a lot of money if they had a PBM. Regarding PBMs in general, if insurance company signs up a PBM, they should lay out everything that the prescription part of the program covers. I am at a loss to say that the insurance company looking for a PBM, do they tell the PBM that they want certain things done, or does the PBM say, this is the package, take it or leave it? Regarding the filling of initial prescriptions for controlled substances, notably the opioids, the limit is for some companies 7 days for an initial prescription, even if the doctor writes for amount greater than that. And we'll talk with the customer and say, do you need this much? Do you want to take, you want to just pay the amount your insurance company covers for the copay, which is frequently only $5 or $10, or do you want to purchase the month's supply the doctor wrote for initially, or even the 2-week supply, as it were? But it's going to cost, $25 instead. And sometimes the customer will say, "Oh, I'm going to need this much, blah, blah, so I'll pay the amount, the retail price for the larger amount." That information still goes into the PDMP file. And if they say, "Oh, I just want to, whatever my copay covers, then that's all I want." So they get the 7-day supply, and have a $5 or $10 copay. So regarding PBMs, that's pretty much the ins and outs of it.
Thank you, Jerry. Can I ask Gary, can you also reply to that, please?
Unmute. Well, I'm here as a private citizen. Now, I know DEA works with public health with the prescription drug monitoring program, right, Jeff? You work in tandem, but I don't really know anything about that end of it. I'm just here as a patient rights advocate.
Okay, thank you. Thank you, Madam Chairman.
If I may, I do have an experience with pharmacists and an insurance company telling me that my patient went to go and fill a prescription, but the quantity that I prescribed was more than what the insurance was willing to pay for. So I can speak to that to some degree. So I'm a neurosurgeon. So I don't prescribe long-term narcotics. I do short-term narcotics. So I do neurosurgery, I do back surgery, lumbar laminectomy. Patient usually require about 2-week prescription of narcotics. Usually is Norco that I prescribe. It's 5 milligrams. It's a combination of Tylenol with the narcotic. I prescribe it at 1 tab every 6 hours as needed for pain. I give 45 tablets, no refills. In one instance, the pharmacy called me and told me that, the patient called me and told me that the pharmacy would not fill a prescription because their insurance only allows for 7 days. Now, mind you, I don't put the amount of days on my prescription. I just put the quantity of pills. So I then had to call the pharmacy and get information as to this insurance rule because I had no idea about this. And they explained to me that, well, 45 pills is way too many for this particular insurance to fill. I then had to give the patients 10 pills instead of 45 pills. The patient then came back to me the following week after 1 week was passed and asked for more, and I gave him another 10 pills. Now, mind you, I am the only neurosurgeon that's seeing outpatient clinic. Because of this, I now have to not see a new patient because I have to see a follow-up patient in order to follow the rules of their insurance company. So that's one instance. There was another instance where, again, I'm not a chronic pain prescriber. I do it for 2 weeks and then I stop. I tell patients before they see me that, listen, I will do your surgery. I will give you 2 weeks of pain pills and that's it. If you want more, you have to go see a primary care doctor, or I'm going to give you ibuprofen, which works as a pain prescriber. And they say yes, and then we go through with our agreement. If they say that, no, I changed my mind, I want narcotics, I tell them, no, you can't have narcotics. In this instance, I prescribed 45 pills of Norco. The patient's insurance company called me and informed me if I was aware that this patient was getting prescriptions, narcotic, from another physician. And I explained to the insurance company that, no, I was not aware and that I apologize. Apparently, the patient was undergoing chronic pain management treatment for something unrelated to why I was seeing him for surgery. So the prescription that I gave him for his pain management, I didn't know that this patient was seeing another physician for a chronic pain problem. And this becomes a problem with this new bill because patients may need different types of pain prescription. Another issue is that Schedule II medications on Guam include things like gabapentin. which is not a pain medication, but it's a nerve pain medication. There is no potential for abuse of gabapentin, but I, as a physician, have to prescribe it as a Schedule II. So that means that I can only give a certain amount, and if I can't call it in, the patient has to come to my clinic to come get it. So this bill will hurt physicians like myself in trying to treat pain in a way that does not allow us to use narcotics. So to not use narcotics, I use gabapentin, which again can treat nerve pain, but has little abuse potential. But because it's Schedule II, it falls under this bill. And so it limits my ability to treat pain in a different way besides using narcotics. I hope this helps make the decision, and thank you for listening to me.
Madam Chair, may I speak to that?
Mr. Caruso or Mr. Moylan? Yeah, okay. Mr. Caruso, yes, Dr. Caruso.
All right, Dr. Naomi. Gabapentin on Guam is not a controlled substance. In some states, I understand it is, because gabapentin will potentiate or increase the effect of narcotics, pain medications issued at the same time. We still see some patients on Guam on both in limited quantities, both for nerve pain and for whatever other pain issues they're dealing with. Gabapentin, again, maybe in some states it's scheduled controlled substance, but technically not on Guam. And not federally either that I'm aware of. Doctors prescribe it all the time. For patients seeing two different physicians, practitioners for two different issues, but being put on narcotic pain reliever by both physicians. I've only run into one instance of that. And it does create a problem because you run into roadblocks trying to fill both prescriptions. The PDMP will give me a notice saying this patient is seeing more than one doctor, is seeing more than one pharmacy, and you look up the information and find out what's going on. You talk to the customer or the doctors and work it out. Ideally, if somebody needs to see two different doctors to have two different prescriptions for narcotic controlled substance, it makes life difficult for everyone concerned. And hopefully that answers some of your questions and concerns.
All right, thank you. So Mr. Caruso, could you just confirm that as a pharmacist, when you are filling a prescription, are you going to be notified each time of this patient's recent history, as far as they've been uploaded, or is it optional?
It's up to the pharmacists right now, to access the PDMP to see what the patient's on, who he's getting medications from. And it's almost like my right arm at work. I check virtually every prescription coming in. I have little doubt that not all pharmacies do that. But I have run into a couple instances where I've had to call pharmacies and say, oh, this has happened, that's happened. Did you know that? And pharmacists say, oh, no, I didn't check. No, they should check.
All right, and thank you. And I want to assure everyone that we are having these discussions regarding electronic prescriptions for controlled substances. They are not a part of this bill, but yes, we have been having these discussions with public health, with the Pharmacy Association, and we will pursue that. Are there, senators, any other questions? If not, all right, then thank you again for all your time this morning and your very valuable input. There being no additional testimony, we will consider Bill 388-35 duly heard. Public hearing is now adjourned. The time is 11:46 a.m. Thank you all.
Thank you.